Well, good morning, everybody trickling in grand rounds today. My name's David Raleigh, and I'm a radiation oncologist and physician scientist in the departments of radiation oncology, neurological surgery, and pathology. And I'm joined here today by Dr. Ann Oberheim Bush, neuro-oncologist, who sees a lot of meningioma patients with myself, and Dr. Ramin Morshed, neurological surgeon and skull-base specialist. And the three of us work closely together in the care of patients with meningiomas here at UCSF, including a multidisciplinary clinic that we established mid last year. And we're here to talk to you today a little bit about meningioma, which, as many folks in the audience may know, is the most common primary intracranial tumor in adults. We have 4, perhaps 5 cases that we'd like to get through today to share with you to talk about some common and some less common but clinically challenging scenarios for patients with meningiomas. These are, of course, very common tumors. It's estimated that there's 42,000 new cases diagnosed every year in the United States, and that there's more than 350,000 individuals who are alive with meningioma in our country. Despite how common these tumors are, there's little consensus on their optimal treatment. Beyond, of course, surgical resection, an acknowledgement that this is neurosurgery brain rounds. Medical therapies remain experimental or ineffective, and even what I do, the radiotherapy part of things, is controversial. Recognition of that controversy, there are currently 2 phase 3 randomized studies of postoperative observation versus postoperative surveillance for patients with WHO grade 2 atypical meningiomas that achieve a gross total resection. And in 2025, I can think of very few, perhaps no other tumor or cancer contexts where we're still randomizing patients to literally nothing or 6 weeks of some of the most cytotoxic therapy known to man. Now, here at UCSF in our meningioma program, these nuances are discussed for every patient at a weekly tumor board that's staffed by neurological surgeons, radiation oncologists, neuro-oncologists, neuroradiologists, neuropathologists, advanced practice providers, and clinical research coordinators. In that program, in that tumor board, we often use, as we will discuss today, genomic information to guide treatment recommendations for patients with meningiomas. These include both targeted next-generation sequencing, which we perform for all meningiomas at UCSF using the UCSF 500 gene panel. RNA sequencing, which we also perform for meningiomas at UCSF, not only to define gene fusions, but also a gene expression risk score that predicts response to radiotherapy, we'll talk about today. DNA methylation profiling, which has become almost standard of care for many brain tumors. And in addition to those genomic biomarkers, we also incorporate advanced imaging, whether with dotatate PET or hyperpolarized C13 carbon, for non-invasive genotyping of meningiomas and identification of occult residual disease or refinement of radiotherapy planning. Those recommendations are relayed to patients at our meningioma multidisciplinary clinic, which happens immediately after tumor board. And last but certainly not least, in partnership with long-established survivorship, caregiver, neurocognitive, and social work programs at UCSF that have been established within neuro-oncology and for brain tumor patients for many years. We additionally have an emphasis and a study focused on living with meningioma, which I would encourage you to screenshot or perhaps take advantage of the QR code here. It's an annual 15-minute survey once a year for every 5 years that we offer to all patients with meningiomas who are seen here at UCSF. So with that epidemiologic and logistic framework as a backdrop, I'd like to turn things over to Dr. Morshed to discuss our first case today. I hope you have a low threshold to let us know if there are any questions or comments you might have. We'll be monitoring the chat throughout this presentation. And if you'd like to, rather than type, speak your question, I hope you'll raise your hand. We'll be trying to pay attention to that as well. Thanks very much. And Dr. Morshed, take it away.
Thanks, David. And thanks everyone for being on the call. I think we formatted today's lecture to be case-based with some sort of points of meningioma care that hopefully will be helpful to everyone on the call. The first case is a scenario that many of us in the brain tumor world see in clinic on a day-to-day basis. This is a 73-year-old female who presented with tinnitus, with imaging demonstrating a right anterior clinoid mass that certainly looked consistent with meningioma. She had no tumor involvement in the auditory canals or the cochlea, and thankfully no vision loss, but certainly no explanation or ties of this tumor to her presenting symptoms. So this lesion is essentially an incidental finding. And the question is, what do we do with this tumor once we see it? We certainly know it's a meningioma, and there's obviously some risk to vision loss in the future with growth, but the patient at this point in time is asymptomatic, otherwise doing well. So I guess, David, just to sort of think about a multidisciplinary discussion about what we would do, what do you think is appropriate for this tumor? Do you think radiation would be appropriate, watching, surgical resection, which I guess I could weigh in as well?
Yeah, far be it from me to weigh in on the surgery part of things. I mean, I think the short answer to your question, Ramin, is yes. It's an incidentally diagnosed asymptomatic meningioma. And so this is, located in kind of a tight spot. And so I think this is inherently a nuanced discussion. And one of my favorite things that we do in our tumor board is, try to engage in a lot of, shall we say, patient-focused decision making. Many people really don't like the idea of having a tumor in their head and would like it out immediately. Other people are a little bit less is more. In this case, even though the patient is asymptomatic, just due to the risk of what I would consider a catastrophic cranial neuropathy, if the tumor grew, I would favor treatment. And even as a radiation oncologist, my favorite treatment for meningioma is surgery, and then more surgery if ever it's feasible. So be curious to know your thoughts about that.
Yeah. And I think, we both help out on the radiosurgery side of this. And I think, the consideration here is the proximity to the optic nerve. Even upfront single fraction gamma knife radiosurgery would not necessarily be feasible in this case. It probably, if anything, would need a fractionated regimen. But I think it's a discussion with the patient, just like you're saying. And in her case, she was asymptomatic. She really didn't like the idea of surgery. I thought it was very reasonable to keep observing this patient. And so far, after about 6 to 12 months, no changes in her vision. And I think it's important to follow these patients objectively with testing that's relevant to symptoms they may develop. So she's getting ophthalmology evaluation with OCT testing and visual field testing. Maybe we can go to the next slide. And so these are all incidental meningiomas that you're seeing on the slide. And I think the question is how to best manage these patients. Incidental tumors are becoming more and more frequent as we use MRIs and CTs more and more for diagnostic purposes. There's some studies looking at asymptomatic patients. If for those screened with an MRI, about 1% will actually have a meningioma. And about 20% of all meningiomas are incidentally diagnosed. And that percentage is likely to just keep increasing over time as the population ages and the frequency of imaging use increases. And again, should we be managing all these cases in the same way? Should we be observing these patients to minimize risk of treatment, or we should be treating them early to prevent problems from eventual meningioma growth? We can go to the next slide. And there's really no current standardized guidelines for the interval or duration of monitoring for incidental meningiomas. In terms of natural history, there's been many studies looking at what the growth rates of these tumors are, but the definitions of what constitutes growth or progression has varied a lot between those studies. So if you look at studies from before 2010, for example, many of those studies suggest most of the meningiomas will grow on follow-up, and they were using diameter measurements to dictate what constitutes growth. More recent studies, however, are suggesting that it's actually more the minority of meningiomas will grow by 5 to 10 years on follow-up. And I think it's important to know that many studies using volumetrics of tumors that have monitored meningioma growth think that meningiomas grow according to this Gompertzian model of growth, where there may be an exponential period of growth, a more linear period of growth, and a plateauing of growth. Obviously, when we see these tumors, they're not just popping into existence. They've had some period of growth previously, but we just don't know where those tumors are falling on this particular curve. And I think it's important to know that meta-analyses that look at risk of symptom development for patients undergoing imaging surveillance for meningiomas is only about 8%. And so we really have to keep that in mind when thinking about interventions in these patients. Now, one calculator that's available to the community is this impact calculator, which we put the link up here just for access. And this is a calculator that's been put together by one of the UK groups in Liverpool. And it's a scoring system that takes into account multiple patient factors, including age, performance status, comorbidities, tumor location, and tumor size, and build that into a model that risk stratifies these patients on if they're going to have disease progression or not in follow-up. So it's a helpful tool, I think. It has not been prospectively validated, and I think the authors of the studies that this calculator is based on are actively trying to do that now. Next slide. And so I think this impact study, which that calculator was based on, just to go into a little bit more depth, is a great study to help guide us in selecting treatment or not for these patients. It was a study conducted by a UK group in adult patients with newly identified incidental asymptomatic meningiomas. And their endpoint for disease progression is important. It included a variety of things: symptom development, meningioma-specific mortality, development of increased peritumoral edema, venous sinus invasion, which could preclude a complete surgical resection, or meningioma volume growing beyond 10 cubic centimeters, which would preclude safe SRS. And then they incorporated a growth definition, which included both absolute and relative growth rates per year. And so this study included over 400 patients that were actively monitored for a median of 3 years. Essentially, the disease progression rate in these patients was quoted to be 11%. With a median time to progression of 33 months. And I think it's important to look at that table there on the left and see, well, look at those progression-free survival rates by 5%. If you're in the low-risk group, essentially not many of those patients are going to progress, whereas if you're deemed high risk, then the majority of those patients will progress. In general, though, the 5 and 10-year progression-free survival for the cohort was 83% and 70%, respectively. So that means that most of these patients will not have progression on follow-up, according to the study's definitions. And I think this is a pretty conservative definition for growth rates and progression. We can go to the next slide. The other part of this study that I think was helpful to see and think about was what the impact is of competing risk. And so what you're looking at on the left are curves in which we're looking at the rates of disease progression and intervention, which are in blue and green, according to Charlson Comorbidity Index and as well as WHO performance status. And the takeaway from these graphs is that if you have a worse functional status, the likelihood that you're going to need intervention or have disease progression detected is lower, probably because there's a competing risk of dying from other causes or being lost to follow-up from other causes as well. And so I think when we look at these natural history studies, we have to keep that in mind, is what is the competing risk of other issues coming up in these patients. I think the study was nice because it has this nice flow chart that gives some recommendations and data-driven recommendations on follow-up intervals. But I do want to point out that the maximum follow-up that the authors suggested was 10 years. And we do have other literature that suggests that meningioma progression, at least post-operatively, can be seen out to 20 to 25 years. And so I think that that 10-year threshold is not a definite one, and we should be continuing to look at this with longer follow-up. We can go to the next slide. Yeah. And so now let's switch gears, because the other study that we often refer to is this impasse study. And this is really a more treatment-focused paradigm for asymptomatic meningiomas. And really the mindset is treating these tumors up front with radiosurgery at the point of presentation to make sure that they never have the chance to grow down the road or cause any problems. And so this was a multi-center international retrospective study, and the outcomes were local control and development of new neurologic deficits and follow-up. And so their definition of disease progression or tumor growth was basically a different definition. It was an increase of 25% of the baseline volume. And so the end results, and you can see here in the Kaplan-Meier curves, these are Kaplan-Meier curves both of the entire cohort as well as a propensity matched cohort, which in general show similar results. But the tumor control rates with upfront SRS were 99%, versus observation, they were 64% in terms of progression-free survival. And so that's a big difference. That means that SRS is obviously, as you would expect, able to achieve very high rates of tumor control in this population. The rates of new neurologic deficits on follow-up were 2.5% in the SRS cohort and 2.8% in the observation cohort. So there really wasn't a difference in terms of new neurologic deficits. So the authors of the study concluded, well, SRS did not increase the risk of neurologic deficit development as compared to observation. But I have to point out, it also didn't decrease the risk either. Some of this data, if you look at it, may suggest that, well, we're achieving very high rates of tumor control, 99%, but also this population probably includes tumors that were never going to grow in the first place or cause problems. And so I think that's sort of the trade-off here, what we're weighing when we're observing or favoring upfront treatment. We can go to the next slide. And so just to get back to this question of, should all these cases of incidental meningiomas be managed the same? The likely answer is that there's some middle ground, that's usually the answer. And I think we haven't had guidelines that really give us definitive management on this. I think that it includes a lot of different things, including patient preference, goals of care. We need to consider structures at risk with future growth. How close is this to certain areas that are going to cause problems for the patient? What's the degree of space from those structures? What are the possible treatment options? If this tumor is on the borderline of SRS, maybe we should consider treating it now versus letting it grow, and then we lose that opportunity and then have to only offer surgery. What's the risk of treatment now versus later? What's the patient's age and performance status? What's the competing risk of death from an alternative cause? And what's honestly the patient's risk of follow-up loss, which is probably an understudied phenomenon. And, for at least the vestibular schwannoma literature, probably as high as 20–30%. So I think these are all things that go into our recommendations for these patients. But I guess David or Nancy Ann, I don't know if you have any other thoughts on this.
Well, I suppose the one thing about the impasse trial as it relates to this particular case that you showed, encircling the right optic nerve, this particular patient, to my mind, is not a candidate for single fraction radial surgery. So that, while we quote those data and use those data in impasse a lot, in this particular instance, if it was going to be radiated, it would probably be a fractionated case. Some people might consider a 5 fraction case. I'm not sure if I would in this instance. It definitely does the location. So much informs my thinking. Nancy Ann, any thoughts on that particular incidental meningioma?
I think the point about Ramin talking about loss to follow-up is quite important. If you have someone that you know is going to be consistent to get their MRIs and to follow this, I think it's much more reasonable to do observation. But if you have a patient that you're not sure is going to follow up, a lot of times that will push us to intervene sooner rather than.
Well said. Well, speaking of incidental meningiomas that maybe require a bit of treatment or get some treatment, Nancy Ann, maybe we can turn things over to you for the second case.
Sure. So this actually was a case that was referred to me. It was an 81-year-old was found to have an incidental left parasagittal meningioma after he was evaluated for lightheadedness. Because it was incidental, unlikely related to his lightheadedness, he actually was observed over time. And it took about 4 years, but he did actually show some growth in his tumor, so much so that the outside neurologist then referred him over to me to discuss treatment options. So due to the slow growth, we were discussing treatment, and this came down obviously to the question of surgery versus radiation. And for this particular patient, he is very, very high functioning and wanted to make sure he had no impact to his neurocognitive function. So I'm going to turn it over to Dr. Morshed and Dr. Raleigh. What would you guys recommend for treatment-wise? Or you gave away what we did, David, but what would you have recommended if he had come to you with those particular concerns, surgery versus possible radiation?
Well, I did bury the lead on this one, in part because I would not have treated this with radiosurgery. I would not have quoted the patient a meaningful risk of neurocognitive dysfunction with radiosurgery for a small frontal incidental meningioma. But this one isn't exactly all that small. Our institutional cutoff for single fraction SRS for meningioma is typically 2.4 centimeters. It's something in that neighborhood. This one's a little bigger than that. And we have prospective phase 2 data from an Italian trial of 5 fraction SRS for large imaging defined or grade 1 meningiomas. And long-term rates of local control with such a treatment are excellent, in excess of 97% beyond 5 years. So I do think that there are reasonable stereotactic options for a patient such as this as it relates to radiosurgery. Not single fraction, maybe 5 fraction. Data is encouraging, although not as mature as single fraction. And so I would very much encourage this patient, who it sounds is very high functioning, to consider a surgical option.
I have to agree with David. I think, I mean, you could offer both options, but honestly, in that discussion, I would be leaning towards surgical resection of this particular lesion for the reasons that David said. I think diameter-wise, yes, you could treat this with SRS. Yes, probably some, added risk of radiation necrosis or some swelling down the road. I would probably just take this out for more definitive treatment if the patient didn't have any medical issues that would preclude general anesthesia, for example. So I think what was done was very appropriate.
Great. And one of the benefits of taking it out, obviously, is that we get pathology. And there has been a real revolution in the field of meningioma that we've really begun to understand in general the genetics of the tumor can predict behavior better than just the WHO grade. And so for a neuro-oncologist, we always like to see pathology, but also we are now doing next generation sequencing on all of our meningiomas. And I can remember, I don't know how many years ago, David, when we started to do this, some very spirited discussions with the pathologists about the benefits of running next generation sequencing on our grade 1 meningiomas, and if it was really going to change management for these patients. We won, so we are doing next generation sequencing on all of our patients. And so this patient, after his surgery, went on to have regular pathology, which was a grade 1 meningioma. I think, David, the next slide might be his UCSF 500. So this is our internal next generation sequencing panel done at UCSF. He had an extraordinarily common mutation that we see in grade 1 meningiomas, monosomy of chromosome 22q, one of the most common, and very consistent with grade 1 pathology. So nothing on this UCSF 500 actually made us concerned or potential change in grade or more aggressive behavior. So this to me actually said, okay, very comfortable continuing to watch this. This may never come back. We're just going to watch the MRI every year for the next 5 years. However, now that we're doing next generation sequencing on these tumors, we are also picking up more things. So this was an 81-year-old gentleman with zero history of breast cancer in his family, but does have 2 brothers, has 4 children, and we actually found a BRCA2 mutation. Because we picked this up on the UCSF 500, we recommended germline testing. So he came in and got a blood draw. We can also send the patients just a kit that they can spit in to do paired sampling to look at germline. And he actually does have a BRCA2 mutation in his germline. So this, of course, led us to send him to genetic counseling, genetic counselor. This led him to actually be recommended to do some screening that would otherwise not have been recommended. He actually was told to go have a mammogram, which he did, which actually picked up breast cancer. So he actually underwent surgery and was found to have a ductal carcinoma. So somewhat of a aside, but definitely a benefit that we're seeing. I actually saw a patient yesterday in his 70s with a grade 1 meningioma that also had a BRCA2 mutation. So this is providing value to our patients and hopefully improving their quality of life.
I believe it was back in 2019 when we started reflexive molecular testing for all meningiomas at UCSF. Since that time, we've accumulated more than 900 consecutive meningiomas with next generation sequencing data. In cases like this are not exactly one-offs. They do seem to pop up rather frequently. These are, of course, very common tumors. The genetic drivers, as you articulate, Nancy, and we're beginning to understand better and better. But certainly we can pick up things in these tumors that suggest other things may be going on.
And just to make a note of how we manage this at UCSF, because we're getting genetic testing on all of our patients, all of the patients will have a consultation with neuro-oncology postoperative, even if it's just a one-off, to make sure these genetics are reviewed and make sure there are no action items need to happen based on this testing.
Yeah, it's very important. Well said. Well, I think case number 3 is me, and this harkens back to that controversy that I shared with you on the overview slide at the beginning of this presentation, namely a gross totally resected atypical WHO grade 2 meningioma. This is a patient of mine, a 76-year-old gentleman who ended up having a whole body screening MRI, was found to have this asymptomatic left convexity meningioma, underwent a resection here at UCSF, and achieved an MRI defined gross total resection. Now, as you may recall from that first slide today, he is eligible for randomization to postoperative radiotherapy, 6 weeks of IMRT, or postoperative observation on either the NRG-BN003 study that's open here in North America, or the EORTC 1308 Rome trial, which recently closed in Europe. Ramin, I wonder if you can share a little bit your thinking about how you manage postoperatively a patient with a grade 2 meningioma who achieves a gross total resection.
Yeah, I think that's a great question. I mean, I think in most cases with a gross total resection, historically, we would have just watched these patients. I think now there's new opportunities for new imaging studies, dotatate, for example. Some groups are starting to use that to really confirm what the extent of resection is. Sending margins, especially for convexity meningiomas, may also be helpful. That's not something that's standard, but some groups are suggesting that we base our extent of resection on inclusion of margin data as well. And so I would say in this patient, I think it'd be a discussion, we would now start thinking about getting a dotatate to confirm a gross total resection before considering radiation versus not. But I bet you a lot of people in the community are not treating this with radiation. I think we would be a little bit more inclined to do this here.
Nancy, any thoughts to build off what Ramin shared?
So I think one of the most important things is harking back onto our next generation sequencing is actually looking at the pathology of these tumors. Because like I mentioned before, I do believe that the genetics of the tumor can predict risk better than just the WHO grade alone. So that would be something that I would be very interested in if this patient had any concerning changes on their next generation sequencing that might help guide our decision.
All very good thoughts, and I will get into all of those, both the genomics and advanced imaging of this case. I will tell you on UCSF 500, this particular patient didn't have anything worrisome or untoward, like a CDKN2AB deletion or a TERT promoter mutation, which would have by definition made this a grade 3 tumor, according to the 2021 WHO update. And, acknowledging that in NRG-BN003 and EORTC 1308, it's kind of an all or nothing sort of scenario with 6 weeks worth of radiation or observation. Here at UCSF and other institutions are hoping to strike more of a middle ground. So we currently have a clinical trial, a pilot study of 5-fraction SBRT available for patients with gross total meningiomas that achieve, atypical meningiomas that achieve a gross total resection. We favor this treatment strategy because copious retrospective data looking at single fraction SRS for atypical meningiomas after gross total resection suggests that rates of control are poor. That's not so much to say that the rates of local control are poor. At the dural attachment itself, the majority of these tumors seem to fail at the dural margins. And adding on a dural margin is something that we struggle to do safely with single fraction stereotactic radiosurgery. But with 5-fraction treatments and advanced physics planning, we are able to address that dural margin, which on this study, which we call the SRS AIM trial, we treat with a total dose of 30 gray in 5 fractions, a biologically very equivalent dose to the IMRT that would be delivered on NRG-BN003 or RTOG, or EORTC 1308. Now, to Nancy Ann's point about using advanced genomic features to guide our postoperative recommendations for patients such as this, we have begun to use a targeted gene expression biomarker that's comprised of 34 genes, which we reported in the literature of a series of papers over the past couple of years, which not only seems to refine postoperative prediction of meningioma outcomes better than histologic grade, but also for the first time sheds light on which meningiomas may in fact benefit from postoperative radiotherapy and which ones we should probably just observe. This gene expression biomarker was initially reported across, I believe it was 1,856 meningiomas from 12 medical centers across 3 different continents. It was developed in a total of 173 meningiomas that underwent resection here at UCSF, and then validated in the rest. And Kaplan-Meier curves I'm showing you here for the gene expression low, intermediate, or high risk scores are just across the clinical validation cohort meningiomas that were not used for the development or training of this biomarker. The gene expression risk score itself is a continuous risk score from 0 to 1, not so dissimilar, perhaps from Oncotype DX, or the Decipher score for prostate cancer. And on the right-hand side of this slide, you can see in these forest plots the value of that continuous gene expression risk score, which provides additional prognostic information in the setting of newly diagnosed or recurrent meningiomas after gross total or subtotal resection, and across all WHO grades, whether defined using histologic features alone, as codified in the 2016 update, or integrated histologic and molecular features as proposed in the 2021 update. Last but certainly not least, and perhaps I suppose that lilac color at the bottom of those forest plots, we can show in multivariate analysis that this gene expression risk score remains independently prognostic for outcomes when we consider newly diagnosed versus recurrent setting, extent of resection, and histologic grade. Now, I intimated this gene expression biomarker can also shed light on which meningiomas benefit from postoperative radiotherapy. And so if we look at the patients in our study who were treated with surgical monotherapy, what I think you can appreciate is across these low, intermediate, or high gene expression risk scores in blue, purple, and red, that in all of these molecular contexts, gross total resection offers a benefit. I often like to say that this represents job security for the neurological surgeons of the world. But if I am being sufficiently self-deprecating, I think we can also Notice that there are distinct favorable and unfavorable outcomes for these patients, even with a gross total resection. Now, if we took patients with favorable or unfavorable meningiomas based on their molecular and postoperative features, what we found is that meningiomas with unfavorable characteristics were the ones that seemed to benefit from postoperative radiotherapy. These are, again, data from patients in our study, and they're based on their gene expression risk scores, patients who were not used for the development or training of that gene expression risk score. And now what I'm showing are those who weren't just treated with surgical monotherapy in the middle and on the right-hand side of this slide, but those who perhaps did or didn't receive postoperative radiotherapy. What I think you can appreciate in the blue curves is radiotherapy really doesn't operate or doesn't offer any benefit either for newly diagnosed WHO grade 2 meningiomas in the middle, the same sort of patients who might be eligible for randomization on BN003 or the Rome trial, or across all histologic grades on the right-hand side. But across all histologic grades on the right-hand side, or specifically for newly diagnosed grade 2 meningiomas in the middle, what you can see is that patients with unfavorable molecular and surgical characteristics significantly benefit from the addition of postoperative radiotherapy. And we have copious retrospective data that would suggest this biomarker is of use for fine-tuning postoperative recommendations for patients with meningiomas. And currently, this biomarker is being incorporated into a developing clinical trial through NRG Oncology, BN2501, which is a randomized phase 2 clinical trial of postoperative radiotherapy versus postoperative surveillance for clinical low risk but molecular high risk meningiomas. The study would be open to patients with grade 1 or grade 2 meningiomas after gross total resection, who, despite those reassuring clinical features, are found to have worrisome molecular features using this gene expression risk score. Patients who meet those criteria would be eligible for randomization either to postoperative surveillance or postoperative radiotherapy, this time either with IMRT or with a stereotactic 5-fraction approach, not so dissimilar from what we're currently investigating on the UCSF SRS AIM trial that I told you about a couple of slides ago. Now, going back to our particular patient in question, they did, in fact, as Dr. Morshed suggested, have a postoperative dotatate PET MRI, which, as I think you can see here, showed a small focus of residual or perhaps recurrent meningioma overlying a blood vessel that was intimately associated with the tumor itself. Now, if you're not familiar with this imaging study, which has been around for a while, but has only recently been used for meningioma patients, dotatate is an SSTR2 ligand that's bound to a radionuclide chelator and can be used for meningioma imaging. Standard FDG PET, as shown on the left-hand side of the slide, is of course very bright in the brain because the brain uses a lot of glucose. But for this particular patient, who was found on a screening PET exam for breast cancer to have a bit of a lucency on the left posterior fossa and an MRI showing somewhat of a regular mass at this region, perhaps consistent with meningioma, or perhaps consistent with a metastasis from what was admittedly a very aggressive locally metastatic breast cancer. This dotatate PET scan kind of put that controversy to rest. Breast cancers, most other cancers, don't express somatostatin receptor, but for meningiomas, we know that somatostatin receptor expression is the most sensitive and specific immunohistochemical marker for the histopathologic diagnosis of these tumors. We use that immunohistochemical stain in routine clinical practice for just about all meningiomas. And we're increasingly using dotatate PET MRI and dotatate PET CT to aid in the diagnosis of meningioma, such as shown in this slide. We also are using this imaging study to define the extent of postoperative resection, such as for this patient who had a very large parasagittal meningioma with brain invasion. And it ended up undergoing a resection at meningioma, showing some signal within the resection cavity itself that on a dotatate PET MRI was not shown to be residual disease, but there was copious invasion of what you can see the anterior and posterior sagittal sinus, as well as some satellite lesions in this particular case. So we've found the dotatate PET MRI is useful for diagnosis of meningioma. It's useful for evaluation of postoperative extent of residual meningioma, and is additionally useful for meningioma invasion into skull base or other bony structures that can sometimes be challenging to resolve on routine anatomic imaging. Here's a patient with no known meningioma history, but a history of melanoma, who was found to have what appeared to be, at first pass, an intraoperative metastasis. Resection, excuse me, an intraosseous metastasis. Resection of this metastasis, presumed metastasis, was achieved, but on pathology, this was shown to actually be a grade 3 meningioma. And on a postoperative dotatate PET MRI, there was a bit of residual meningioma that was identified within the bone itself. And as a radiation oncologist, this information was very, very valuable for designing a radiotherapy field that appropriately treated not only the residual disease, but also a margin to account for microscopic spread along the dura and within the bone. On this topic of, shall we say, more clinically aggressive meningiomas, moving farther and farther away from the incidentally diagnosed tumors we started with, I'd like to turn things back over to Nancy Ann to talk about our fourth case.
David, I just would like to put a plug in too for dotatate. It's amazing for neuro-oncologists as well to be able to see these tiny little meningiomas places and be able to follow them. We're not typically using it on a recurrent basis, so we're not getting them with a MRIs. All right, case for multiply recurrent meningioma. So this is a 45-year-old female who presented with headache, diplopia, and nausea. She had a left sphenoid wing meningioma that was first resected back in 2014. Had grade 1 disease followed. Progression in 2017, again resection called grade 1, again followed. In 2019, again had progression, another surgery, again called grade 1. And then after that, actually, because this was her third progression, wound up having fractionated radiation. She had 54 gray and 30 fractions. And she did pretty well with that until 2022. And at this time, again, had progression and had a subtotal resection. And this time, her meningioma was upgraded to a grade 2 progression. Grade 2 pathology. And then again, had progression in 2023. So had another surgical resection. So I just want to point out a 45-year-old now with 1, 2, 3, 4, 5 surgeries. This is one of those grade 1 that we talk about that maybe don't act like a grade 1. This was a young patient. And, you know, in 2023, we were finally doing some genetic testing. So I'd like to show next slide, see what we have. Okay, this is an example of her last 2 surgeries. So on the left, you can see that left sphenoid wing meningioma. It was not able to be taken all the way out, but this was debulked. And it was debulked enough that our radiation oncologists felt comfortable treating this with a fractionated radiation with 5 fractions. David, I believe it was 5 fractions, correct? Yeah. So this was really important to us because we thought potentially she could be eligible for one of our clinical trials using immunotherapy in conjunction with fractionated radiation. So sometimes, even if we don't think we can get the whole tumor out, having a patient get a debulking surgery so that we can perform fractionated radiation potentially in the conjunction with a systemic therapy would be something that we would absolutely consider. So I'd like to highlight a clinical trial that we have open right now at UCSF. It's an open label phase 2 study looking at stereotactic radiosurgery plus immune checkpoint inhibition for patients with grade 2 and grade 3 recurrent meningioma. So this is open to anyone with a grade 2 or grade 3 who's already had radiation therapy and has confirmed pathology. So they must be recurrent. They must have already had radiation. The intervention is SRS. If it's less than 8 cc's of volume, you can do 1 fraction. We can actually treat patients up to 20 cc's with a 5 fraction course. And with that, you're given pembrolizumab on the first day of your radiation, and then every 3 weeks until progression, unacceptable toxicity, or up to 2 years of treatment. At this point, we're in progress. We've accrued 22 of our planned 37 patients to date. Our primary endpoints include progression-free survival at 12 months, with secondary endpoints of overall survival, progression-free survival, median progression survival, safety, neurocognitive function, and quality of life. So I wanted to present a little bit of preliminary data, David, on this. So this is our preliminary data. So still work in progress. But what we found is a median progression-free survival of about 8.7 months, and a PFS6 of 72%, and a PFS12 of 40%, PFS 12 months of 40%. with an overall survival of 30 months. I would like to point out that the 22 patients that we've enrolled so far, more than 50% are grade 3 pathology, so very aggressive tumors, and the median number of recurrences prior to starting this treatment is 5. So extraordinarily heavily treated patient population of very aggressive tumors. And although this isn't a comparative study, there have been 2 studies now that have been published looking at immunotherapy as a sole agent for treatment of recurrent grade 2 and grade 3 meningioma. And this data would suggest a possible benefit. These results are better, although again, we're not finalized, than immunotherapy alone for recurrent patients.
Yeah, Nancy Ann, so often we sit in a CNS tumor board with a recurrent glioma or glioblastoma, talking about what we're going to do for our patients. And, I said earlier in this session that my favorite treatment for meningioma is surgery. And so often in CNS tumor board, when we're talking about glioma patients, our surgeons will ask us, well, okay, surgery, but then what? What are we going to do next? What does this buy us? This trial answers that at least for meningioma. Ramin, knowing that these patients on this study have undergone, Nancy Ann, you said a median of 5 recurrences before. The surgical planning for these cases, it's a lot of multidisciplinary discussion, a lot of nuance, understanding what can likely be removed and what's left behind for the radiation oncologist to address is nuance. Can you speak to that at all?
Yeah, it's very complicated. These patients often have multiple craniotomies that may be in multiple pieces that are sort of puzzle piece back together. The radiation that many of these patients have had can make the skin very thin, posing them risk of wound dehiscence and infection after surgery. Once we get into the dura and open the dura up, there's often a lot of scar tissue. It is very dependent on where these meningiomas are stuck to. And that can all be limiting in terms of the amount of tumor that can be removed during the case. And so, yes, I think as you pointed out, we're often thinking, well, what's going to happen afterward? Hopefully I can get all the tumor out, but even if I can't, what's going to be the game plan? And we certainly don't want to turn these patients into cases where we, so to speak, whack-a-mole, where we're just seeing lesions pop up and then trying to, take these little nodules coming up with surgery over and over again. There has to be other options.
And one option with the systemic therapy is theoretically you're treating everything. So we have had some patients with multiple meningiomas, albeit one is really growing, the others might, treating the one with gamma knife with immunotherapy and theoretically, hopefully, targeting all of the lesions to prevent them from growing. Sure. So this is a nice trial for patients who have multifocal disease, whose surgery may not be an option for them as well, I would say.
I want to also, I'm going to say something that's a little bit of a aside here, but often at surgical meetings, there are some out there that comment that radiation induces changes in these tumors that can lead to malignant transformation or risk of further progression on follow-up. And I certainly don't think our group here really ascribes to that. But I think the truth is that many of these tumors from the beginning are probably bad actors for reasons that are probably dictated by their molecular features as opposed to just the WHO grade. And so these are the tumors that probably from the beginning are high risk and they're going to come back over and over again. And it may be that the histology at the time when they were initially diagnosed with grade 1, just the histology itself looked reassuring. But if you were to have looked at the molecular features back then, maybe we would have seen some high risk features that would have predicted progression. And so, I'm curious to know your guys' thoughts on, obviously this trial we're using it in multiply recurrent meningiomas. Maybe we should be using this earlier if we know that these patients are bad actors from the beginning.
I think that's certainly a great idea. I think sometimes it is challenging for patients who have a first or a second recurrence of a grade 2 meningioma that have been dealing with it for 10 years to commit to getting immunotherapy every 3 weeks. So I think that's one of the challenges that I've had. They're like, well, if you radiated, it probably will come back again in 10 years. Do I really want to go on this trial? But I could have paid you because I think that your discussion on the genetics of the tumor and whether or not they're bad actors is kind of perfect for the particular case that I was mentioning. I don't know if David, if the next slide is about her. So just kind of going back to her. So from the beginning, her pathology looked really like standard grade 1. Only in the future did it look like standard grade 2, but there was nothing really special about it other than it being like, it looks like a grade 2 now, not a grade 1. And as you can see from this graphic, she had a pretty impressive tumor that kept growing back. So here are some images between her 4th resection to her 5th resection. It really was a very large tumor. After that 5th resection, that was the time that we had the genetic testing of the patient. And she actually had something very interesting. So she has an MLH1 loss, which is a DNA mismatch repair. And so here's some H&E staining of that. So you can see loss of MLH1. When you have loss of MLH1, you actually have degradation of PMS2. And so that's showing some immunohistochemistry showing that in her. But she has retained MSH2 and MSH6. So on her UCSF fund, when we found that, interestingly, there wasn't really any, despite having a mismatch repair, there wasn't like a huge immune response or a lot of immune infiltrated cells that you really picked up on classic histology. However, treatment for her, we did put her on our clinical trial with the stereotactic radiation with immunotherapy. And what happened was really striking. I think David will show us, hopefully, is that we treated her with immunotherapy and the SRS, and her tumor completely melted away. And not only has it melted away, but there's been a durable response. This tumor hasn't grown back for over a year. And so there has been one other case report of meningiomas with mismatch repair having this dramatic response to immune checkpoint inhibition. And this is just another example. So this, again, really suggests that we do have to be doing next generation sequencing of these tumors. We wouldn't have picked this up on classic histology. And this could have saved her a lot of treatments and a lot of surgeries if we had known about it sooner because of this dramatic and durable response.
You know, Nancy Ann, I was her radiation oncologist, as you mentioned earlier, and I can take no credit whatsoever for this tumor shrinking away. We know, or we think, that about 1/3 of meningiomas might shrink by about 30% after radiotherapy. This tumor had already been radiated, had certainly never done anything resembling shrinking over time. And while I did target that tumor that you can see as a residual, I had no expectation that it would shrink. Even the ones that do shrink can take many years to, and within 3 months it had melted away. It was a truly dramatic response. Well, acknowledging that we've got a couple of minutes left, I think 6 or 7 at this point in time, maybe we can transition to our last case. A case of an anaplastic grade 3 meningioma that's recurrent after surgery, radiotherapy, and salvage therapies. Not so dissimilar from our 4th case that Nancy Ann just presented. We know that there are meningiomas which need more than surgery and radiotherapy. Now, mismatch repair mutations in meningiomas are, I suppose, somewhat unfortunately rare, given the dramatic response that Nancy Ann just shared. But we do know that more broadly, meningiomas can be classified into 3 molecular groups. Groups that have been alighted on by separate investigators, not only here at UCSF, but also at Baylor and the University of Toronto. Those groups are associated with distinct biologic drivers, clinical outcomes, and therapeutic vulnerabilities. And we call them Merlin intact, immune enriched, and hypermitotic meningiomas. These are consensus groups that can be defined based on DNA methylation profiling of meningiomas. But there are certainly characteristic copy number variant alterations and gene expression programs within these tumors. And it is notable that this molecular grouping scheme is an unsupervised hierarchical analysis of meningiomas, not one that is, let's say, trained on a clinical endpoint the way the gene expression biomarker that I shared with you earlier is. So this is a patient that Nancy Ann and I shared together. Nancy Ann, perhaps you'd like to present her case.
Sure. So patient, again, very unfortunate, multiply recurrent grade 3 meningioma. She had a subtotal resection. She's actually treated with proton radiotherapy. Over time, her tumor began to grow. Prior to meeting me, she was started on bevacizumab as a salvage agent. And what happened, and part of the reason why she was started on bevacizumab, her tumor was growing, but she also developed a right eye blindness. Her vision did not get better. The bevacizumab stabilized it for a short period of time, but then she started to grow again and developed worsening vision in her left eye. So she was effectively going blind. So for that patient, we treated her with stereotactic radiosurgery, and things progressed, that things got even bigger, and she started to lose even more vision of her eye. So what we did next is we gave her a targeted agent based on the fact that she had CDK2A2B homozygous loss, but also in David's classification, she really looked like one of those hypermitotic meningiomas. So her cells were dividing very rapidly. So she was started on abelaciclib, which is a CDK inhibitor that's brain penetrant. We were able to get it covered for her by her insurance. And we started her on that drug, and actually things got better. Her tumor decreased in size, and most importantly, her vision was restored in her left eye, so she could see again because the right eye was really gone. So a huge clinical impact for this patient, as well as improvement of her tumor size, which was fantastic, on a targeted agent for patients with either CDK2A2B deletion or what we think of as hypermitotic or rapidly growing meningiomas.
And we're working to incorporate this agent, of course, in another trial through NRG Oncology, BN015, that would bring this agent into the upfront setting, as we were discussing, maybe more broadly with immunotherapy and other medical therapies for meningioma. But as monotherapy, this agent has, of course, been reported in this Alliance study. Nancy, would you like to summarize these?
Sure. So this is an Alliance phase 2 study using this drug for recurrent meningioma with NF2 or CDK pathway alterations. So it's a clinical trial, again, that's recurrent grade 2 or grade 3 meningiomas, but you have to have one of these molecular pathway alterations. You get the abelaciclib BID until tumor progression or toxicity. I would like to mention, this is not the easiest medication to take. About 80% of patients will develop diarrhea. We're able to manage that usually with medications, but it is something that pretty much everybody will get, so you got to let them know. And for this patient's 36 of 36 planned patients over 13 months accrual with a primary endpoint of progression-free survival at 6 months and response rate. And so far, the results have a 6-month progression-free survival of 54% in this patient population, no objective response rate in the 24 evaluable patients at this time.
Yeah, so I think it's fair to say that there's a lot of excitement around these new therapeutic strategies for patients with meningioma, be it abemaciclib or immunotherapy or refining radiotherapy or radiosurgical paradigms under molecular guidance. I think one thing that still somewhat remains for many patients with meningioma, going back to our incidentally diagnosed cases, which are, of course, the most common types of meningiomas we can see, are non-invasive approaches to understand the biology of these tumors. All of our understanding of the therapeutic vulnerabilities and biologic drivers of meningioma come from resected tumor tissue, which is, of course, both diagnostic and in many instances therapeutic and is very clinically warranted. But as Dr. Morshed intimated earlier on, we are diagnosing more and more meningiomas because of increasing use of brain MRI. And so understanding what direction these meningiomas are going to head is very important. The best available data we have from dotatate PET MRI doesn't necessarily suggest that we can use that particular study to differentiate a bad actor from a good actor when it comes to a meningioma. But here at UCSF, we are using metabolic imaging with MR spectroscopy to define the DNA methylation groups of meningiomas that I told you about on the last slide, those same DNA methylation groups that perhaps predict susceptibility to abemaciclib and certainly seem to portend favorable or unfavorable clinical outcomes. This imaging study uses hyperpolarized C13 carbon and takes advantage of the Warburg effect. And using these hyperpolarized carbon tracers, what we think we're able to do is to delineate hypermitotic in red from immune enriched in purple from Merlin intact meningiomas in blue. This is also a clinical trial that's available for patients with meningiomas at UCSF. We're doing this in the preoperative setting for both suspected, otherwise known as newly diagnosed, and recurrent meningiomas. So we hope you'll have a low threshold to reach out to any of us if you have any questions about the therapeutic strategies or data that we've shared with you here today. Acknowledging that we're just about at the top of the hour, just refresh your memory about the different things that we're doing for meningiomas on a regular basis in our tumor board and multidisciplinary clinic. You can find our email addresses on the bottom right-hand corner of this slide. I'm happy to hang online if there are any burning questions or comments that anybody would like to share.
I'm going to field a question from Dr. Theodosopoulos here. Sorry, we have to use our laptop here.
Hi, great job, all three of you. And I think really, really important issues that you brought up. A quick question about dotatate. I mean, there's a ton of other questions, but just about dotatate and the fact that we do see stuff post-op now that were we to know pre-op, we may have done a different operation altogether or potentially significant changes in the operation. Should we be doing dotatate PETs up front to assess involvement of bone of the skull base, etc.? Because or not, and it brings up the issues of the logistics also of dotatate PET that we may have to work on. But we at this point we only use it at recurrence or after treatment, after surgical treatment.
Yeah, that is a predictably excellent question, Philip. It's something that Javier and I have talked about a lot over the years, most recently last week. Because Javier, I wouldn't want to speak for him, but I would say that there was multidisciplinary enthusiasm for protocolizing this imaging study and doing it, perhaps in the setting of a clinical trial or a prospective registry. I would defer to yourself and Ramin regarding the utility of that study in the preoperative setting, the postoperative imaging setting, or in the setting where we're using radiotherapy for definitive treatment of meningiomas. I have personally found it to be inordinately useful. Ramin, do you have any comments?
Yeah, I mean, I completely agree with Philty. I think, if you get this pre-op, say you have a convexity meningioma, it could potentially change what your exposure needs to be if you find out the tail actually goes out further than you think it does. So that could change the surgical setup. People can use it. I mean, we see plenty of these incidental cases that we're not 100% sure is it dotatate or meningioma or not. So I think actually there is some like diagnostic benefit sometimes of getting this in the preoperative setting if there's any doubt that we're going in to take out a meningioma. Certainly I've already seen, lymphoma mimic meningioma just last month. So I think that it has some sort of preoperative diagnostic utility as well. And especially for recurrent meningioma, if we're ever going in for a recurrent meningioma and really thinking about, well, what's our true target going to be? Because often those are little lesions that we're going in and trying to remove. Yeah, I think it would be better to know if there's a general region that's all positive that we'd have to take out going in ahead of time. So I think there are plenty of examples and situations where I think it could be helpful in a preoperative surgical planning phase.
Yeah, and most of these mimic my thoughts. And I would say this, David, also because we do get it so frequently pre-radiation, getting it pre-surgery could actually suffice right there, because then we know we can overlay it on whatever post-op scan we have. It's not going to change dramatically the PET in a month or two. So I think it may also be just one scan before surgery, and then we can make our decisions. And then in cases like the one you showed, where there was the one that had multiple little things, not regionally, but further away on the skull or in the skull base, I mean, that should also give you an idea of what kind of tumor you're dealing with, which we don't usually expect to have, aliquots of meningioma far away from the main lesion.
Yeah.
Certainly at presentation, that may give us an understanding of that we're dealing with a more aggressive actor.
That's a great point. And I love the idea of one scan preoperatively, right? Which we can use for radiotherapy planning. We sometimes, of course, will see occult residual disease on dotatate post-operatively. Now, that being said, I don't think we rightly know what to do with such data. A lot in cooperative groups, a lot of people say, oh, that dotatate focus, that's where the tumor is going to come back from. That's where it's going to fit. But we don't know that, because all our data about meningioma recurrence and patterns of failure are based on MRI data.
Yeah.
Yeah.
Okay, well, here's the charge, I guess, because we're running late here. The charge would be that we need to set it up all together and get it going.
Yeah, I think you're right about that.
So work in progress. We're working on it now.
Any other questions from anybody else? Thank you for that question and comment. All right. Well, thank you all for your time and attention today. Please do reach out to any of us if you have any more questions or comments. And yeah, thanks very much.
Thanks,
Everyone.
everyone.